We have a 65-year-old male patient, hypertensive, not diabetic. He presented, his first complaint was burning chest pain. Burning was misdiagnosed as GIT upset. Until the pain was severe, he went to another doctor who made cardiac enzymes were elevated. The ECG was a little bit deceiving, as there was T-wave inversion in the inferior leads only. And then he was, the doctor took him to the cath lab, and he did him coronary angio and found that the posterolateral branch of the right ventricular PL branch was totally occluded. Then 2 months after, he started to have ventricular tachycardia, which was hemodynamically unstable, went to the emergency room and received this shock. Ejection fraction was 40%. Cardiac MRI was done, and it showed a scar in the infralateral part of the left ventricle, and the ventricular tachycardia will show you where it was, and he received dual ICD as class 1 indication for secondary prevention of ventricular tachycardia in ischemic cardiac patient. Actually, the MRI said an additional finding of non-compaction, and I think it was overdiagnosis. The patient, after he received his ICD, started to have many shocks. We'll see his programming, and his ventricular tachycardia was sometimes causing syncope, although it was terminated by anti-tachycardia pacing and sometimes by shock, but he was collapsing. So we reprogrammed him to have the shock early and the anti-tachycardia pacing early. He kept having his tachycardia, so we gave him a session of ablation, and we'll show you the plan. First, we did CAR2. بعد كده I will show you the tracing كده. يلا جون معنا. This is CAR2. We started, the plan was to do deep channeling, voltage map, and okay. We started to do, it was only one catheter mapping, RV pacing catheter, and the CAR2 to minimize all the expenses, and for this reason. We started by the voltage map, and meanwhile, when we identified this car, we were identifying areas of late potential. The blue dot is the far potential from the QRS complex, and the white blue was with the potential close to the QRS complex. The white ones are pace mapping of these sites which have good potential. Jhone معنا, كمل بقى جون.
I'm always in such medium-sized scar. I'm focused on the scar, so I did not draw the whole LV myocardium. He is 71 years old under general anesthesia, so you must focus on the actual scar. The scar in the MRI was basal to mid infralateral, and that's verified by the CAR2. And in the border zone, and even inside the scar, we could see a late potential, as we can see here, a late potential. Also, is clearly post-systolic potential. Another one. You can take this one. This one. Yes, it is post-systolic delayed potential. Then after substrate mapping, we highlight the area of 12 of 12 base match and of the clinical VT. We have already the 12 lead ECG of the clinical VT. So in the lateral border of the scar, here, we could see the inferior view, s'il vous plaît, inferior view. Yes, and up, yes. This is the inferior view of the heart, and this is the septal wall, and this is the lateral wall. In the lateral wall of the scar, okay, all this area induce 12 of 12 base map of the clinical VT, especially the mid area. The basal area give us 12 of 12 of another clinical BVC. So our target to ablate such area which show the post-systolic potential, the late potential, and also inside the scar. In the septal border, we could find also a late potential, post-systolic potential, or it is not related to the clinical tachycardia, but we ablate it because of to avoid further attack of VT. Lately, after our work, we induce the tachycardia. We do a post-pacing. We do extra stimulation protocol up to triple extra stimulation from RV and LV to see if it is there is inducible tachycardia or not. And thanks God, there is no any inducible tachycardia forever. So we end the procedure and it's identified as success of ablation. Thank you. A clinical ECG of clinical VT. We could see that it is arising from LV. The transition is at V3, V4. And the axis is superior axis, so the origin of such tachycardia is the mid-segment of lateral wall, which verified by the CAR2 substrate mapping. We could see that very rapid tachycardia of heart rate about 230 to 140, causing syncope for the patient.
Okay, this is this episodes. We'll show you from this here, rhythmic episodes, open data. This is one of them, which was yesterday. As you can see, this is the VT, and the antitachycardia pacing terminated it. Another one. Because of his syncope, we made the detection of these episodes shorter. We'll continue the interrogation to go to the previous episodes. These are today's episodes and yesterday. Okay. He received dual ICG, and that's very good because he was atrial paced most of the time from sinus bradycardia, from medication and so forth. He was on amiodarone, Enderal, and anti-ischemic treatment. He's on Plavix, he's on Brilic and aspirin. We'll continue with his antiplatelet medication, and we'll see. Now we are interrogating the previous episodes. As you can hear, he is in the recovery. Okay. We'll show you the one for which he received shock. Ahead, one of them. This is here. This is the VT. Actually, he syncoped. This is anticardia patient did not recover, and then faster VT, faster, and then he received a shock and terminated this episode. You can see on the 21st many episodes here, and he received also another shock here. That was 10 days ago, immediately after implantation, but that was in the VF zone where he had syncope at home from this very fast rate. Shock recovered him. Another shock, which were 1 minute difference in between. Another one, VF detection, F detection, and shock, and recovered to his sinus rhythm with some V pacing. So that was almost another one ahead. That was almost a VT storm in this patient. We decided to do him this ablation. So that was successful. It was minimal areas of ablation targeting the channel that was the channeling. The patient he has recovered now. He'll go back to his room. He will be kept under observation with the same medication. Thank you very much.